Good morning. I am Dr. Anitha, MDS, Assistant Professor, working in Vinayaga Mission, Sankaracharya Dental College, Salem. So today's topic, it is on alveolar bone. Let us see the contents. So, introduction, definition of alveolar bone, development of alveolar bone, its composition, parts of alveolar bone, functions, remodeling and repair, blood supply and nerve supply, age changes, and the clinical considerations. So to start off with, you should know what an actual bone is. So bone is nothing but a specialized connective tissue that is mainly characterized by its mineralized organic matrix. So coming to alveolar process. So how this alveolar process is different? The alveolar process is the portion of maxilla and the mandible that forms and supports the tooth socket. So it forms when the tooth erupts to provide the osseous attachment to the forming periodontal ligament, and it disappears gradually after the tooth is lost. So in this first picture, you can see this green coated area, it is the alveolar process, and you can see the alveolar process is present as long as the teeth is present. And in the second picture, you can see this blue coated area, it is of alveolar process. Next, in this picture, you can see in the mandible posterior region, there is no teeth in it. So the alveolar process is also, it is not seen in the posterior region. Whereas in the anterior region, you can see the 4 teeth which is present along with the alveolar process. Next is alveolar bone histology. So all mature bones, they have a dense outer sheet of compact bone and the center medullary cavity. The cavity which is filled up with red and yellow bone marrow. So in this next picture, it shows a cross-sectional view of maxilla and the mandible. And in this picture, first picture, you can see the tooth cross-section and which is surrounded by the alveolar process. And in the second picture, you can appreciate the mandible. It is a cross-section view of the mandible. You can see the outer compact bone layer and the inner trabecular layer. Right? Then comes your macroscopic structure of bone. This picture, it is your longitudinal section of mandibular bone, and here you can see the tooth apex, and below which you can see the alveolar process as such, and the outer part, it is your compact bone, and the middle part, it is your trabecular bone. So in this picture, the size and shape, location and function of the teeth determines the morphology. So coming to the definitions of alveolar bone. So according to the Orban, the alveolar process is defined as that part of maxilla and the mandible that forms and supports the sockets of the teeth. So according to Carranza, the alveolar process is the portion of the maxilla and the mandible that forms and supports the tooth sockets. That is your alveoli. So next to the development of alveolar process, how this alveolar process develops. And you can see in this picture that it depicts the end of the second month of fetal life. That is the maxilla as well as the mandible, it forms a groove that opens to the oral cavity, and the tooth germs contained in these grooves are alveolar vessels and nerves. If you see in this picture, you can appreciate this is your tooth germ, right? And this groove, it is the bone of the mandible, and you can see here the inferior alveolar nerve, it is developing. And here it is your Meckel's cartilage, right? And I've put it in a flow chart. So if you see, when a deciduous tooth is shed, it has fallen off. What happens to its alveolar bone? Its alveolar bone gets resorbed. And what happens to the alveolar process? It gradually is incorporated into the maxillar and the mandibular body. Next comes your permanent tooth. What happens to the permanent tooth if it moves into the place? It develops into its own alveolar bone and it forms its own follicle. So with the onset of the root formation, the interradicular bone develops into a multi-rooted teeth. So what happens if the teeth is separated from each other by the development of interdental septas? So coming to the composition. So you all know the bone, it is made up of organic and inorganic substances. So this organic substance, it constitutes about 67%, that is mainly of hydroxyapatite content, and this organic portion, it constitutes only 33%, of which you can see the collagenous proteins and the non-collagenous proteins along with the cells like osteoblast cells, osteoclast cells, osteocytes, that is your bone lining cells. So what are all the collagenous proteins? It composes of type 1 collagen, and this non-collagenous protein, it consists of thioproteins, osteocalcin, osteonectin, osteopontin and your proteoglycans. So next, moving on to the parts and structure of alveolar process. It has been divided into two parts, that is your alveolar bone proper and your supporting alveolar bone. So what is this alveolar bone proper? So it is nothing but the inner socket wall of thin compact bone. Suppose if you extract the teeth, you can see a thin wall of bone which is a compact bone. That lining is called as alveolar bone proper. This supporting alveolar bone, it consists of cortical plates and a spongy bone. So in this picture, it is clearly depicted all the parts of the alveolar process. Like first part you can see in this picture is the compact bone, thin compact bone which is lining the extraction socket, that is your tooth containing socket, that is your alveolar bone proper. Then comes your supporting bone. This supporting bone in turn it has two parts, that is your cortical plates, and then inner it is your spongy bone. Now we are going to deal in detail all these four subtopics. That is, first comes your alveolar bone proper. So it has three terms. It has been termed as cribriform plate. It is an anatomic term for alveolar bone proper. So this is, next is your lamina dura. That is your radiographic term of alveolar bone proper. Then comes your bundle bone. It is the histologic term of alveolar bone proper, which is coined by Steen and Weinmann, right? It consists partly of lamellated and the bundle bone. So what about its thickness? It will be around 0.1 to 0.4 mm thick. So then you need to know about the terminology called Sharpie's fibers. So what is the Sharpie's fibers? It is that bone in which the principal fibers of the periodontal ligament gets attached or anchored, right? So in this picture you can clearly see the alveolar bone proper which lines the socket wall. This is your alveolar bone proper. It is a thin layer of compact bone, and this is your surrounded by your cancellous bone. Then the outer thick cortical bone, right? Then it contains only fewer fibrils than the lamellated bone. So since bundle bone contains more calcium salts per unit area than the other type of bone tissues, they appear as radio opacities in the X-rays. You can see a thin radio opaque line followed by the tooth apex root. It will be continuous with your tooth root. That is also called as lamina dura. So next, moving on to the lamellated bone. What a lamellated bone is? So it contains, here this picture shows the structure of a lamellated bone. So it contains osteons. This is the osteon, of which it has a blood vessel in it. This is your Haversian canal, right? So this blood vessel is surrounded by a concentric lamellae to form a osteon. So then moving on to the bundle bone. So the bone in which the principal fibers of periodontal ligament are anchored. So you all know what the principal fibers of periodontal ligament. There are 5 fibers, right? So the term bundle because bundles of principal fibers that continue into the bone as Sharpie's fibers. So what are Sharpie's fibers? Here you can clearly see the Sharpie's fibers here. They are mineralized at the periphery and they have a larger diameter. So these fibers, they are numerous than the corresponding fiber bundles in the cementum. So if you see it radiographically, as I have already said you, this lamina dura, it has been appeared as a radio opaque line which is continuous with your tooth root. Correct. So then moving on to the supporting alveolar bone. So it consists of, as I have already said you, it consists of cortical plates and your spongy bone. So first let us see about the cortical plates. So it makes up to 80% of the body of the mandible, and where it is thicker and where it is thinner. So it will be thinner in the maxillary region and it will be thicker in the mandibular region, and it will be thicker in the premolar region and the molar region of the buccal sides of the lower jaw. So the supporting bone, it is usually very thin in the anterior region of the both the jaws. So this is again the longitudinal section of the mandible. It has been divided into two parts. That is till the apex of the tooth root. That is the part which is above the tooth root, it is your alveolar process, and the part which is below the apex of the tooth is called as body of the mandible. And here you can see the mandibular canal, and here you can see the outer cortical bone and the inner cancellous bone. Moving on to the cancellous bone, it has three terminologies. Again, it is also called as paunchy bone, that is the anatomic term of cancellous bone, and it is the trabecular bone, which is a radiographic term of cancellous bone, and the cancellous bone itself, it is a histologic term, right? So if there is a presence of trabecula enclosing the irregular marrow spaces, which is lined with the layer of thin flattened endosteal cells, and there is a variation in the trabecular pattern, which is all depending upon the occlusal forces, that is how much of occlusal forces has been exerted on that particular bone, right? So then moving on to the interdental septa. So what is this interdental septa? It is nothing but they are the bony partitions that separate the adjacent alveoli. You can see in this picture coronally, this you can see the CEJ here, that is 1 mm apical to the CEJ. Both these plates, they fuse to form an interdental septa here. Moving on to the osseous topography. So normally this alveolar process, they conforms to the prominence of the roots. If you see in this picture, you can see the root prominences here. So it follows the root prominences. This is your alveolar process, right? And it conforms with that of the prominence of tooth roots. So as soon as you say a bone, the two terminologies that should flashes into your mind should be the periosteum and the endosteum. Whatever the bone is, you should know what a periosteum and endosteum is about. So as the name itself implies, perio means, peri means around, endo means inside. So the outer fibrous layer, it is called as periosteum, and the inner cellular layer, it is called as endosteum. So in this picture you can clearly see this periosteum, it is the outer part here, and it consists of osteocytes, etc. And this is your endosteum, which is present inside. Here you can see the bone matrix, the osteocytes, which is embedded inside. Moving on to the next picture, here you can clearly see the Haversian canal, and here is your concentric lamellae, and there will be a blood vessel inside this concentric lamellae. So here it is the interstitial lamellae. Alright. Then what is the functions of alveolar bone? What it does? So it houses the root of the teeth, that is anchoring the tooth roots to the alveoli. So it helps to move the teeth for better occlusion, and it helps to absorb and distribute the occlusal forces which is exerted on them and which is generated during the tooth contact. So it supplies blood to the periodontal ligament area, and it houses and protects developing permanent teeth while supporting the primary teeth, and it organizes the eruption of permanent and the primary teeth. So it provides attachment to the muscles. So coming to the bone resorption, this bone resorption and the bone formation, it happens throughout our life. So let us see what a bone resorption is all about. So bone resorption, there are various sequence of events that takes place in this resorptive process. So as I've already said you, there are more number of bone cells, that is 4 types of bone cells, in which the osteoclast, which is responsible for the bone resorbing process. So here comes the flow chart of attachment of osteoclast to the mineralized surface of the bone. Then what happens? As soon as the osteoclast attaches to the surface of the bone, it creates some sealed acidic environment through the action of proton pump, which determines the bone, and it exposes the organic matrix. So after this, organic matrix has been exposed and it degrades, and the enzymes like acid phosphatases and cathepsins, it goes and contacts with the amino acids, and it sequesters all the mineral ions and the amino acids which they come in contact with. Moving on to the various bone resorbing factors. So first is your systemic factors, then comes your local factors, then comes your bacterial factors. So what role is present in systemic factors? So the parathyroid hormone PTH and parathyroid related peptides, vitamin D3, thyroid hormone, and coming to the local factors, you have prostanoids and cytokines like interleukin 1, interleukin 4, interleukin 6, tumor necrosis factor alpha and beta. Then comes your bacterial factors. So the toxins of bacteria like LPS, lipopolysaccharides, capsular materials, peptidoglycans, etc. So then comes your bone modeling. bone modeling and then your bone remodeling. First we will see what a bone modeling is about. So bone modeling, it is defined as a change in the shape and architecture of the bone. So it extends from the embryonic bone development to the pre-adult period of human growth. So which is continuous process. As I have already told you, this is a continuous process, and the ability of bone to adapt to the mechanical loads is brought about by the continuous resorption and your formation. So then moving on to bone remodeling, what it is? It is defined as a change, that is bone, there is a change in the bone without the concomitant change in the shape and the architecture of the bone. So there is a homeostatic equilibrium resorption and the formation which is balanced. In that case, the old bone is continuously replaced by the new tissue. There is new bone cells, they help in forming the new bone tissues. So this ensures that mechanical integrity of the bone is maintained, but it causes no global changes in the morphology of the bone. So as I have already said you, it is a complex process involving the hormone and the local factors acting in the autocrine and the paracrine manner on the generation and the activity of differentiated bone cells. So in this picture you can clearly see there is a bone resorption happening here and there is a bone formation happening here. Let me tell you the process. So here, starting from here, there is a resting bone surface here, upon which there is a osteoclast, that is a pre-osteoclast gets attached to the resting or mineralized bone surface, and the resorption process has begun with the active osteoclast. This happens within the 3 weeks, right? And there is a mononucleated cells which adhere to the resorbed areas. And then again this pre-osteoblast, they get attached to the resorbed area, and there is a reversal of this process. That is, the osteoblast, they go occupy the resorbed bone surface area and then they help in the bone formation. So as I have already told you, the osteoblast, it is nothing but your bone forming cells, and the osteoclast is nothing but your bone resorbing cells. So here what this osteoclast do? The osteoclast, it resorbs the bone surface, whereas here this osteoblast gets attached to the resorbed area and then it helps in the bone formation. Then comes your osteocytes, it finally gets adhered to the newly formed bone surface and helps in the maturation of the formed bone. Okay. So all this happens within 3 months. Moving on to the blood supply of alveolar process, that is, it receives the blood supply from the inferior and the superior alveolar arteries. That is, both maxilla and mandible has been supplied from the above arteries. Then in this picture you can see the venous drainage, that is, venous drainage of periodontal ligament accompanies the arterial supply. So the arteriovenous anastomosis bypasses the capillaries here. Here you can clearly see this is the trigeminal branch, and here this inferior alveolar artery, it emerges through the mandibular canal, and if it emerges through the mental foramen, it is called as mental artery. So this is your sublingual artery, and maxilla, it is supplied by posterior superior alveolar artery, inferior superior alveolar artery and the middle superior alveolar arteries. So moving on to the nerve supply. So the labial aspects of the maxillary incisors, canines and premolars, they are innervated with the superior labial branches from the infraorbital nerve, and the buccal aspect of the maxillary molar regions, they are innervated branches from the posterior superior alveolar nerve. So the palatal aspect by the greater palatine nerve, and except for the incisors, which is innervated by the long spinopalatine nerves. Here you can see, appreciate in this picture, and in this picture you can see the course of mandibular branch of trigeminal nerve, that is your inferior alveolar and the mental nerves. Here you can see this is your inferior alveolar nerve, it passes through the mandibular canal and it supplies all the roots of the posterior teeth, and it emerges out through the mental foramen, and hence it is called as a mental nerve. So the lingual aspect of the mandible, which is supplied by the lingual nerve, and the labial aspect of the mandibular incisors and the canines, they are supplied by the mental nerve. Buccal aspect of the molars, they are supplied by the buccal nerve. The nerve enters the periodontal ligament through the Oaksman canal of the alveolar bone. So coming to the age changes. So what will happen if we age, we progress with our age, we advance with our age? So similar to those occurring in the remainder of the skeletal system, like fracture progressing. So fracture, we are more fracture prone, that is, aged person, they are more fracture prone. So this osteoporosis, they continues with the aging. So there is a decreased vascularity of the alveolar bone. There is a reduction in the metabolic rate, and the healing capacity reduces as the age advances. So the bone resorption may increase or it may decrease, it depends. And there is a more irregular periodontal surface. So in this picture you can clearly see, as in this first picture you can see there is a presence of teeth, and so the alveolar process is present. And here there is no teeth and the alveolar process gets resorbed, and as the age advances the bone is resorbed on the whole, and you can see the facial profile of the aged person. So coming to the clinical considerations, so you should know these two terminologies like fenestration and dehiscence. So what a fenestration is? So it is nothing but the, let me tell you what is it, and let me show you this in the next picture. So fenestration, it is an isolated areas in which the root is denuded of bone and the root surface is covered only by the periosteum and the overlying gingiva. So it is termed as fenestration. So what is dehiscence? This denuded areas, they extend through the marginal bone. That defect is called dehiscence. So why this both are important is because they complicate the outcome of periodontal surgery. So let me explain you in the next picture. So you can clearly see in this picture, so this particular tooth, that is your 3-2, it has a fenestration where your marginal bone is intact, right, and this bone is exposed, this tooth root is exposed, it is denuded of bony surface. So you have a marginal bone intact here, here the bone is missing, exposing the underlying root surface. This is your fenestration. Moving on to 3-1, here you can clearly see the dehiscence, there is no marginal bone over here and it is completely denuded of bony surface, and this defect is called as dehiscence. Is it clear now? So moving on to the management of fenestration and dehiscence. So there are several treatment modalities which has been available for this. Let us see one by one. So you can ask the patient for a root planning, you can convince the patient for root planning along with the chlorhexidine mouthwashes, and then you can go for a full thickness mucogingival flap surgery with a primary closure, and you can give a free gingival grafting over there. So then comes your gingival GTR. This is your guided tissue regeneration. You can take a membrane and you can place it on the defect, and then you can close the flap, do a flap surgery, then suture back. Then comes your combination of bone grafting and your free mucosal graft. Then the last one is your recent advances with a PRF membrane, which I have done in our college during my PG time. So let me show you the pictures of that. A female patient, she is around 40 years of age, and she came to our department with a periopical cyst. You can appreciate in this radiograph. So you can see a periopical cyst over there. So this was an interdepartmental case. We perio, endo department and the prostho department, we all three departments, we worked on this patient, and this patient's chief complaint was pain in the upper anterior region. So there was a when we have taken a radiograph, there was a periopical cyst in the root apex. So what we have planned is, we have planned for a flap surgery. So as soon as we designed a flap surgery, we were about to elevate the flap, we have found there was a dehiscence. This defect is a dehiscence because there is no bone covering here. There is no marginal bone which is intact here. So this is a dehiscence. We have encountered this problem. So immediately what we have done, so in order to cover this dehiscence, we have taken a osteograft, and we have taken osteograft to fill the periopical cyst area. We have enucleated, and then we have put a bone graft in that periopical defect area. We have closed the periopical area. Then we have taken a PRF, which is a second generation platelet concentrates. That is, we have taken blood from the patient, then we have centrifuged it with the test tubes, and then we had compressed into a membrane like this, and then we have placed over this denuded area, that is your dehiscence. Then over which we have placed the flap back, and then we have sutured it. We have given a simple interrupted sutures. So patient was very happy that all her chief complaint was sorted out, and immediately after that the root canal treatment was also done side by side, and then we have given her a prosthetic replacement FPD for that particular 3 teeth alone, that is your 1 1, 1 2 and 2 1. And after 6 months we have taken an X-ray, that is IOPA, which depicts there is a complete resolution of periapical cyst. And this is your pre-op radiograph, this is your post-op radiograph. You can appreciate the difference. Okay, let us move on to the conclusion. So at the end of this lecture you should know the whole anatomy, histology and physiology of the alveolar bone. Right, the bone is a mineralized connective tissue which is relatively flexible character, and it has a compressive strength. And in order to maintain the stability and the integrity of the bone, it constantly undergoes the remodeling. So with all this knowledge, it helps the clinician in diagnosing any problems, and it helps in the treatment planning, which leads to a favorable outcome of the surgical procedures which has been performed. Okay, and this is all the references from which I have taken. Thank you.